Hi, everybody. Welcome. People are just coming in. All right, I'll give it another 10 seconds. I see the participant number is climbing. It's fantastic to see all of you joining today. Thank you so much for being with us. All right. Okay. So for the sake of time, I'll get started. Hi, welcome. My name is Tina Fahim. I'm one of the principal investigators on this project. This is a project that is actually funded through the Public Health Agency of Canada. And our goal is to share vaccine information and provide supports around vaccine uptake and understanding vaccines to long-term care homes and retirement homes. So wonderful to see you all today. And we are going to be giving a vaccine town hall today about just vaccine 101 and updates on COVID-19 and influenza vaccines. And I'm really excited to introduce our speaker, and I'll do that in just a minute. So before we get started, we just wanted to acknowledge the land on which we live, work, and operate on. So Toronto is part of the Dish with One Spoon Covenant territory and is the traditional and ancestral land of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Haudenosaunee, and the Wendat nations. It's land that is part of Treaty 13, signed with the Mississaugas of the Credit in 1787 and the Toronto Purchase 1787, 1805, and 2010. It's still home to many diverse First Nations, Inuit, and Métis people. And by acknowledging the land, we acknowledge our treaty responsibilities in sharing this land and to the Indigenous people who have been the traditional caretakers of this land since time immemorial. And we reflect all of you to reflect on your relationship to this land, the Indigenous peoples, and broader understandings of reconciliation as it relates to health, and have provided a link if you'd like to learn more. All right, so just a couple of quick housekeeping items. So this town hall is being recorded. We'll have a question and answer session at the end. You're more than welcome to put your questions in the chat or raise your hand when the time comes. If we can't get through all the questions today, we'll make sure that you have our contact information. We can compile and answer the questions and circulate after the fact. We want this to be as useful as possible. And just to note that the Q&A session will not be recorded, so please use this as an opportunity to have kind of open discussions. All right, so really excited to introduce our speaker, Dr. Allison McGeer. So Dr. McGeer is an infectious disease physician, researcher, and educator. She's a senior clinician scientist at Sinai Health and a professor at the University of Toronto, and really one of Canada's top scientists in this field. We've had the pleasure of working really closely with Dr. McGeer at the height of the COVID pandemic, and her team really supported a lot of the work that we did in the long-term care and retirement home space. So really excited. I won't take up too much more time. And with that, I'll hand over to Dr. McGeer. Thank you so much.
Thanks very much, Tina, and good afternoon, everyone. Welcome to the town hall. I will just also acknowledge that, like the folk at Unity Health, I am living and working in Toronto, the traditional lands of the Huron-Wendat, the Seneca, the Mississaugas, the Credit. I'm grateful always to have the opportunity to live and work on this land. Now I've just got to figure out how to do slides. Sorry, everyone. Okay, so this is a Vaccine Plus program that aims today to improve knowledge and confidence in COVID and influenza vaccines, to help with staff literacy and understanding vaccines and vaccines information, and to improve the capacity to support staff uptake of COVID-19 and influenza vaccines. I'm going to talk a little bit about vaccines in general, about what the season is likely to bring in flu and COVID, and what we know about recent vaccine efficacy of these vaccines, and then talk a little bit at the end about challenges with particularly staff vaccination in long-term care. Okay, as noted, submit your questions. You can type them in the Q&A box or put your hand up. If you have a question in the middle of the presentation, please do put your hand up, because Tina and Sarah will be watching for the questions that need to be answered in the course of it. Otherwise, put your hand up at the end of the talk or in the Q&A to talk about it. This slide is the declaration of my conflicts of interest. I have research funds that come to my institution for projects from a variety of companies that make vaccines, as well as Canadian research funders, and I have also received honoraria for advisory boards and for speaking from a number of for both pharmaceutical companies that make vaccines and medications and organizations that support education for healthcare workers. And I'm also a member of the Canadian Adult Vaccine Alliance, which is an alliance that is working with government to try to make sure that vaccines that are recommended by our National Advisory Committee on Immunization become funded for people who choose to take them in Canada. Okay, so let's start with thinking about what happens when you get an infection. You look at the top of this, a pathogen gets through your skin, through your mucous membranes, in through a cut. It meets cells called macrophages, and those macrophages respond to it as foreign, say, we need an immune response to this. They stimulate T lymphocytes. The T lymphocytes go on to make a number of killer cells and cytotoxic elements at the top that fight the infection. They also stimulate B lymphocytes, which are the types of lymphocytes that make antibodies. And in the end, you get this combined T cell and B cell response to the infection that makes you get better from the infection. Now, you can appreciate that this takes a little time to organize. And so often when you first meet an infection, let's say you first get a case of measles, you get sick because your immune response isn't fast enough to stop the infection in its tracks. You see at the bottom of the slide that when you initially respond to the infection, you also make memory cells. And the purpose of those memory cells is to allow your immune system to work faster the second time you meet the foreign antigen. So the second time you get exposed to measles, your memory cells say, I got this, okay? And everything moves much faster. And you never even know you got exposed to measles because the measles virus, while it may have infected you, gets stopped in its tracks at the beginning. You think about this in terms of vaccines. What a vaccine does is it allows your immune system to practice on an antigen before it meets the real thing. So it's exactly what happens with an infection. You get the vaccine injected, the protein or the mRNA that makes a protein in the vaccine, you end up with this protein that is recognized by your immune system. Your immune system sets up to fight it. It lays down memory cells. And if later you get exposed to the actual bacteria or virus, you respond much faster and better. So just like training for a marathon or practicing with your hockey team, okay, the purpose of a vaccine is to let your immune system practice on a particular pathogen so that when you get an actual infection, you get a better, faster immune response and you end up not getting sick. When we originally made vaccines, okay, I think 60 or 70 years ago, when the first vaccines were made, we didn't know a lot about the immune system. And so people fundamentally took, for instance, the bacteria that causes whooping cough, you kill it with something, and then you inject the combination of all the different proteins that are part of this because you don't know which one is going to be the one that protects you. And those vaccines work well, okay? Initial vaccines against all sorts of things, but they tended to have a bunch of side effects because you got a very well-stimulated immune response. You got sore arm and sometimes a fever and aching. And so people have spent a lot of time over the last 60 or 70 years trying to find the single protein that gives you the best response to a particular bacteria or virus and will protect you for a lifetime. So an ideal vaccine has one protein in it, and that protein creates an immune response that will protect you for life. We can't do that with all vaccines yet, but we do have some, and we're getting closer. Then now you have a protein, but you also have to deliver it to people. And so that means it, it has to be made in vials or syringes. It has to be able to be stored in the fridge or at room temperature over a period of time. So it needs generally speaking, some other chemicals to keep it in solution in the same way that, when you make a cake, right, you have to have things that will cause the cake to rise and give it some body. And so you need some additional salts and buffers to keep the protein stable. And with some proteins, you also add things called adjuvants that give you a better local immune response, so better training for your immune system. Think, wearing better shoes if you're running marathons, right? You run faster and do less damage to your feet if you have that extra pair of shoes. So adjuvants are like that. And finally, of course, what we really like with vaccines is they don't have to be injected, that you can take them orally or by nasal spray. And for most vaccines, that's the piece we haven't made yet. But we do have an increasing number of vaccines, including our flu vaccines, which are now a limited number of proteins, not just one, but a small number. And COVID vaccines are just one protein, right? So you get the mRNA for it. The mRNA is turned into a protein in your cells, but it's just a single protein. Down at the bottom of this, you can see the other thing you can do now is look on the Canadian website, and you can see absolutely everything that's in every vaccine. We've got the number of things that are in vaccines down to such a small number that you can look at them. Those take some practice because some of them have fancy names, right? Lipids all through your body with names that are chemical names that are syllables long. But you can actually look and make sure you know what's actually in every vaccine that you're getting now, which is great. Okay, now there are some caveats to this, and the big caveat to this is the RNA vaccines, and both influenza and SARS-CoV-2 are RNA vaccines. And here's where we get into trouble, okay? If you think of us as humans, okay, we have 23,000 genes, and as a woman, I can have the maximum of 17 or 18 children if I'm working really hard at it. What that means is that my DNA cannot afford to make mistakes in copying eggs that will turn into children. Because if the DNA copying makes mistakes and the genes aren't right and my cells don't function, that child is going to die in the womb, right? So it has to be correct, because if it makes a mistake 17 times out of 20, I'm not going to have any children and humans will die out. It's really simple. But RNA viruses are different, okay? RNA viruses actually use your cells to replicate themselves. They don't have their own machinery. They've only got 12 genes, and they can have millions and millions of new virions produced by the work in your cells. And what that means is they don't have to worry about copy control. They don't have to worry about making identical copies. They can have copies that have all these mutations that change their proteins. And sure, most of those changes will result in viruses that don't survive. But some of those changes will result in viruses that survive just fine, but are different. And what that means is that RNA viruses, influenza and COVID, evolve much faster than humans. They're continuously changing, and they're continuously changing their surface proteins. And that means we need new vaccines just to keep up with their evolution, distinctive from most vaccines for other viruses and bacteria, right? 1 measles vaccine, 3 tetanus vaccines, some things are for life, but flu and COVID, unfortunately, are not, because they evolve. Okay, so now let's talk, what do we care about in long-term care? And this is just one of the papers that looks at the distribution of different infection types in residential long-term care homes, and you can see that in all of them, and they're private and they're not private, doesn't matter. Respiratory tract infections are always the most common and most serious infection in long-term care homes. There are also common and serious infections just in the general population. So this is a publication from the Institute for Clinical and Evaluative Sciences in Ontario, and here's strep pneumo and influenza and respiratory syncytial viruses as general infectious disease causes of death. So in some ways, long-term care homes are not special or different than the rest of the population. Things are just more concentrated inside. And of course, in addition to individual infections, long-term care outbreaks occur commonly with respiratory infections. And that is because long-term care homes are different than the general population in that the people who live there require a lot of care, and there's a lot of crowding. So it is very easy to transmit infections from one person to another in a long-term care home, always. And this is the summary of the number of outbreaks. We have about 700 long-term care homes in in the province. And in 2024-25 season, there were 800 COVID outbreaks, 400 influenza outbreaks, 110 RSV outbreaks, and 958 with other viruses. So it's not just the infections themselves we want to prevent in long-term care. It's also about not having outbreaks, because outbreaks, in addition to infection, add a great deal of disruption and other harms for both residents and caregivers and staff in long-term care. Now, there's three things you can do to make homes safer from respiratory infection. And one really important one is thinking about the design of long-term care in getting larger spaces and having single rooms and concentrating in smaller units. We're learning things about air handling, both with more exchanges per hour and with some pretty interesting new technologies that may help. But obviously, all these things are important and people are working on them, but they're in the long term, right? So the other two things that we can do at the moment are about infection prevention practice, which we're not talking about today, but also about vaccines. And here's the vaccines against respiratory pathogens that are recommended by Canada's National Advisory Committee on Immunization for long-term care homes for residents. High dose or adjuvanted influenza vaccine, COVID-19, twice a year still, RSV and pneumococcal conjugate vaccine, and for staff, influenza and COVID-19 vaccine. And influenza vaccines have been around for a long time. You know lots about them. So what's new and different for this year's influenza vaccine? The first is that there have been some really big randomized controlled trials in Denmark and Spain that confirm what we knew from an initial randomized controlled trial now about a decade ago, that high-dose vaccine is better than standard dose vaccine for older adults. So that just nicely validates the fact that we are using either high-dose vaccine or adjuvanted vaccine for all older adults in Ontario. There is ongoing surveillance that says that we really can't tell the difference between adjuvanted and high-dose vaccines, so either vaccine is acceptable for older adults. And the other change for this year is that all vaccines, flu vaccines, now have 3 strains in them instead of 4. We used to have 2 different types of influenza B circulating. They were called B Yamagata and B Victoria. During the COVID pandemic, B Yamagata has disappeared. Now, it's not for sure that it's gone forever. People are watching carefully. But at the moment, we don't need it in our flu vaccines, and we don't want things in our vaccines that we don't need. So B Yamagata has now been dropped from all flu vaccines. And so what's in your flu vaccine is 1 H3N2, 1 H1N1, and 1 influenza B, which is the B Yamagata. And at this time of year, we're also interested in looking at what's has happened during the winter season in Australia, right? We just had summer, Australia just had winter. So their influenza season is July, August, and September. And always we look at what we know about influenza vaccine effectiveness in Australia as a potential warning for what's coming. And here you see the estimated vaccine effectiveness against influenza, different types of influenza in Australia this summer. Again, a really important marker is that influenza vaccines are not nearly as effective as we would like. What they are, of course, is much better than nothing, right? It's really important to remember that we have a tendency to think that if you get a vaccine, it should be 100% effective. And 2 doses of measles vaccine is pretty close to 100%, okay? But many of the other preventive things we use, so think about, cleaning your hands, taking antihypertensive medications, taking medications for diabetes. These are all things that are clearly imperfect, but much better than nothing. And influenza and COVID vaccines are in the same category. So, so far, it looks like we're going into the season saying that influenza vaccines will probably work just about as well as they usually do. Now, you'll notice that I've not put a slide in about what this influenza season is going to look like. And the reason for that is that you never know what an influenza season is going to look like before you get to it, okay? It's just fundamentally unpredictable. But I will say, well, we're thinking about influenza vaccines, that there appears to be an early vaccine season in some parts of Asia. You might have seen news stories about Japan and Malaysia. And there is a new and different AH3N2 strain that seems to be very active now in some parts of the world. And so there is a concern that we're going to have a big H3N2 season and that it will be mismatched, which is, I have to say, a really good reason for focusing on getting as much influenza vaccine into staff and residents of long-term care, because it's, again, way less than perfect, not going to make the season go away, but will definitely make things better. So what evidence do we have that influenza vaccines make things better in long-term care? And I want to show you two things. This is some of the first evidence that influenza vaccines specifically in long-term care make a difference. And this was a survey study done by Colin Stevenson a long time ago now, before we used as many vaccines. And you can see on the left-hand slide the percentage of residents vaccinated going from less than 70% to greater than 90%. And the risk that a long-term care home would have an outbreak went down from 56% to 35%. So about a 40% decrease in the risk of having an outbreak in any given year as resident vaccination rates climb. And on the right-hand side, you see the same thing. The distribution of percent vaccinated was much broader at that time, but you see the same steady reduction that tells you that the higher you get your vaccination rates, the less likely it is that you're going to have an influenza outbreak. And that's because influenza outbreaks are defined not necessarily by each individual vaccine, but by the sum total of the number of people who are in the home who've had their vaccines. It's also a measure that it's not just about residents and staff in long-term care. It's also about contractors who come into the facility. It's about essential care providers who come in. It's about other visitors who can come in. Everybody who gets vaccinated in that whole group of people makes a difference to the risk of outbreaks. The more you can do to encourage vaccination across everybody involved in long-term care, the better off you'll be in terms of outbreaks. And here's the second piece of evidence, and this is relatively complicated and was completely unexpected. So these are all randomized controlled trials of healthcare worker influenza immunization in long-term care. What these studies did was they took a group of long-term care homes in different countries, and they randomized them to offering the vaccine to staff of long-term care and making it convenient for them, versus standard of care, so not changing what was done to offer vaccine. And the first of these trials was done in Scotland, and it was actually, they also randomized residents to special offers of vaccine versus whatever was done usually. And you can see at the end of the season that in the homes that had offered vaccine to staff in long-term care, 12% of residents died. And in the homes that had not offered influenza vaccine to long-term care, 17% of residents died. And that difference was statistically significant. That was a big surprise to everybody when it happened. We were not expecting that vaccinating staff in long-term care would have anything like that great an effect. And of course, when you see unexpected things in randomized controlled trials, then you want to understand them and you want to replicate them. You want to make sure that it's true. So there have been 3 more randomized controlled trials, 2 in the UK and 1 in France, looking now specifically because of this first result at whether efforts to increase vaccination rates in long-term care homes, staff of long-term care homes specifically, would result in fewer residents dying during the winter season. And you can see that in all of them, in the homes that were randomized to not offering vaccine to staff, there was a higher fatality rate in the residents in that home than in the homes that were offered staff vaccine. So we know that vaccinating staff in long-term care homes not only protects the staff from getting influenza, but also protects residents from getting influenza and from dying of influenza which of course occurs much more commonly in residents than in staff. Okay. And do we need to worry about staff vaccination? So this is a graph of staff influenza vaccination rates in hospitals in green and in long-term care in blue. And the good news is always congratulations to long-term care. You do better than we do in acute care, and we are very grateful for that. But you can also see that our rates in the last few years are somewhat lower than they used to be. And so just a measure that we need to keep working on increasing influenza vaccination rates. So now let's talk COVID. Okay, so first, of course, the good news about COVID, and the good news about COVID is that mortality rates in general have declined dramatically from the initial 2 years when we didn't have vaccines down to 2025, when it looks like there's practically no cases. Unfortunately, that's only relative. There's still lots of cases going on. And you can very clearly see the difference in impact in long-term care. So there's 2 studies that I could find. The blue is a study in Vancouver that went from 2020 to 2022, and the orange are Ontario data from Public Health Ontario, looking at the case fatality rate of COVID-19 in residents. And you can see that it started out at 27%, and with vaccines and with repeated infections, it's now down at about 2%. And here's an expansion of that, 1.5%. But even though it looks really low from 2022 to 2026, you can see that it's still declining over time. So it may be that over the next few years, that COVID will become less and less severe, even in long-term care. Or it might be that COVID is going to settle out where it is now. We just don't know whether it's going to keep getting better or whether it's going to sit where it is. And that will in part determine what the recommendations are for COVID vaccines for the next few years. You just have to keep watching and assessing the severity. And then you use that severity to determine whether people need COVID vaccines, how often, and what other precautions we need to make about outbreaks. So now just go back and look for a moment at the comparison of COVID-19 and influenza. Last year, we had twice as many COVID-19 outbreaks as influenza vaccines, more than twice as many cases involved. But if you look down at the bottom at the case fatality rate, that's the percentage of residents with COVID or flu who died, you can see for the first time that COVID-19 is a less serious disease now than influenza, which is really good news. It's just the not so good news is there's still a lot of outbreaks and a lot of cases. And even though the case fatality rate is low, if you look at the number of residents of long-term care who died last year, very similar for COVID and influenza. So we're still stuck with wanting to make sure that we have as few COVID infections and as few outbreaks as possible. Okay. So what's happened with COVID and what's going to happen with COVID? As you all know, if you've been working in long-term care, we had a little wave of COVID at the end of August and through September. And here's now Public Health Ontario data of percent positive tests in the black line on top, and then number of people hospitalized due to COVID in the bottom, and they track exactly as they should. And somewhat surprisingly, there's been really substantial decline in the last few weeks, which is lovely, but doesn't help us with what's coming next, right? And so this very messy slide is an illustration that fundamentally tells you we don't know what's coming next. You would think that 5 years in, COVID would have settled into a seasonal pattern like other seasonal respiratory viruses, and that we would know what was coming. But the truth is, we don't. And all of these different colored spaghetti lines here are all of the different infectious disease modelers across the United States trying to model what's going to happen to COVID this season. And you can just see it's all over the map, right? There are some people who say we're going to get through the season with very little activity in these bottom lines. And there's some people who say we're going to have a season that looks like an average flu season. And there's no way of knowing which is going to be right. And then if you look at the little black dots are what's actually happened. And some people predicted that it was going to start climbing in August and September, but nobody predicted this decline. So here's the predictions for COVID this year. Okay, it's called Hope for the Best. Maybe we'll have a season with next to no COVID in the winter season. Wouldn't that be a treat? But prepare for the worst, which is maybe it's going to be a winter season that comes with influenza and is about the same size as influenza, and it's going to cause as much trouble as last year's season did. Okay. Now your next question is going to be, okay, so what variant is coming and how well does it match the vaccine? And these are American data because the American graphs are prettier than the Ontario graphs, but otherwise they're exactly identical, which tells you that most of the COVID now is this variant called XFG. XFG means it's recombinant, but doesn't really matter what it is. It just is what it is. The relevant question is, how closely does it match the vaccine? And so LP.8.1, got to admire virologists for their naming of things in incomprehensible ways, right? LP.8.1 is what's in our vaccines. XFG is what the current strain is. And this square graph tells you in two-dimensional distances how close antigens are to each other. And here's, whoops, now I've got it in the wrong place. Sorry, here's LP 8.1 and XFG down in the corner, and you can see that they're less than 1 square apart. Last year's vaccines are KP2 and JN1, which you can just read up in the middle and further apart. So the good news is LP1 is a close match for XFG this season. And so we're expecting that, again, COVID vaccines will work well, but not perfectly. And here's COVID vaccine effectiveness from 2 US studies last year. We don't have Canadian data yet. All of them saying COVID vaccines now looking a lot like flu vaccine. Again, imperfect. Be nice to have something better, but much better than nothing at all. Okay. Now, lastly, this is what you have to remember, right? Vaccines don't actually protect anybody unless you get them out of the vial, right? Generally speaking, our biggest issue with vaccines not protecting people well is the issue of getting vaccines into people, particularly for adults, right? But in general, really good pediatric vaccination programs. Still in Canada have very high confidence, as we should, in pediatric vaccines and lots of people getting vaccinated. But we have more trouble as adults getting the vaccines that NACI recommends. And so thinking about how to get vaccines into people is critically important. And so why is this hard, right? You know, there's lots of things that we do in prevention that we, do routinely, right? We all stop for red lights. We all stop at stop signs. Mostly we don't speed and we don't speed too much, right? So there are lots of things that we do as a community to protect ourselves and to protect people around us without thinking twice about them. But vaccines are always difficult. And the bottom line is vaccines are always going to be difficult because of the psychology behind them and because of the way human brains are wired, okay? So there's 3 pieces to this thinking about decisions to get vaccinated. The first is that prevention is always a hard sell, okay? And Harvey Feinberg, who used to be the director of the Institute of Medicine, the U.S. advisory body to the government on medicine, has a really nice series of explanations of why it's hard as humans to do prevention well. And here's the list, right? I saw a story last week about what happened to baby Jessica. Some of you are old enough, you may remember baby Jessica, who got stuck in a well in Texas for some very long period of time, and that rescue was very exciting, right? You see stories about kids who died in car accidents without their car seats, right? But what you can't see are stories about the kids who lived because they were in their car seats, right? So when you save lives with vaccines, those lives are statistical lives. You can't point to people and say, that person is only alive because they got their vaccine, because you don't know which person it's going to be. The rewards are in the future, right? It is always hard to take a risk for future rewards, and we don't do that well as humans. The benefits are not just to me. If I get a vaccine, the benefits are to other people, and that's hard. COVID-19, lots of changing and inconsistent preventive advice, right? We base our advice on science, and science grows and changes, but that means advice changes, and change is hard, right? We don't feel the same about areas of omission and commission, right? If I give you a vaccine and you get an adverse event for that vaccine, I feel very badly about it. If I don't give you a vaccine and you get influenza, rationally, I should feel just as responsible, right? Because I could have protected you, but I don't, okay? Because something that I do makes me feel more responsible than something that I choose not to do, always. We accept avoidable harm as normal, okay? People get influenza, you know? It's just one of those things. People die in car accidents. It's one of those things. And so one of the ways that we're preventing car accidents, right, if you think about it, Vision Zero in Toronto is about reimagining things as not normal and then trying to make those things avoided because we believe them not to be normal. We have a double standard for evaluation of prevention compared to treatment. I can promise you in my role as infection prevention and control that it is much harder to persuade my institution that they should be investing in electronic monitoring for hand hygiene, which will improve hand hygiene and save lives, than it is for them to invest in an MRI machine, which will diagnose more cancers and will save lives, right? It's treatment will always be favored over prevention. These days, vaccines are made by large pharmaceutical companies, and you would be right to worry about the conflict of their commercial interests. The way our capitalist system works is that vaccines companies are there to make a profit for their investors. They may have good people in them, their products may save lives, but it's not their primary purpose in life, and that obviously always corrects commercial interests that we need to regulate and we need to be careful of. And sometimes vaccines conflict with personal, religious, or cultural beliefs that we need to understand and deal with. So no matter what preventive thing you're doing, it's always going to be hard. The second thing about vaccines is that we don't behave as humans rationally about risk. And this is, if you have a moment, this New York Times article now from a long time ago from the person who used to be the director of risk communication at the Harvard School of Public Health, is about why smart brains make dumb decisions about danger. And you see the man hiding from a chihuahua behind a tiger, which is just about the fact that our brains are not wired to treat risk completely rationally. And here's his list of things that alter our perception of risk from the rational and actually true to how we feel. And the easiest thing for me always to think about is, you know, what is the biggest risk to you about going on holiday to the Caribbean? It feels like it should be the plane ride, right? Because plane rides are relatively foreign. You don't get a choice about them. You don't have control over them. You're in something man-made, right? But the actual biggest risk is your drive to the airport, right? That's driving is a common thing you do, right? And so we all do this with risks all of the time. If we didn't do this with risk, nobody would live in San Francisco because the earthquake is coming. People would not live on floodplains, right? There are lots of things that where we don't behave rationally about risk, and that's okay, that's human, but it does mean for vaccines inevitably that we are anxious about vaccines, that we worry more about vaccines than perhaps we rationally should. And then the third issue is about the degree that decisions are about trust. So when I take my car in to the mechanic and he looks at it and says, Allison, you need to get your brakes fixed, I do not say, okay, Carlos, explain to me exactly why I need my brakes fixed and what needs to be done and how much it's going to cost. I say, yes, thank you, Carlos, right? Because he's worked on my car for a long time and he knows my car much better than I do, and I trust him absolutely that he's going to make the right decision about my car. And most of the decisions that we make in life are about trust in somebody else who we think knows more than us, telling us what to do. And so we have obviously the same issue with vaccines. We need vaccines recommended to us by somebody that we trust to be giving us the right information and to be giving us information that is in our best interest. And so always when you think about who's recommending vaccines, you need to be making sure that the people who are making recommendations about vaccines are the people that people who have to make decisions can trust. Okay. So then last thing to think about, now you know that getting improvements in vaccine, that having high vaccination rates is always going to be ongoing hard work. There is no simple solution to it because people are always going to be worried about it. People will never do as well with prevention as they ought to do. The second thing that's frustrating about vaccine programs is that there are no miracles. There's nothing that you can do that will take vaccination rates from 20% to 80% with one thing. But the contrary good news to that is that there are lots of things that you can do that will improve it in small measures. And if you just keep working at them and just keep adding things and just keep renewing things, then your vaccination rates will get better. So here's a summary list from a number of the systematic reviews that have been done about things that we know increase vaccine uptake in healthcare workers. Anything you can do about education and promotion, incentives to get vaccinated of any kind, peer vaccination, role models, increased access, simple things. A lot of people not getting vaccines is people not just prioritizing them enough to make the time to do it. Anything you can do to make it easier for people will increase vaccination rates. Audit and feedback. How are we doing this year? Better than last year. Declination forms, people doing education programs or signing forms that say they understand what the risks are of them refusing vaccines. And vaccinator mask policies where people are offered a choice about either being vaccinated or wearing a mask, because now we know that both of those interventions work for vaccines. And so really thinking about staff vaccination each year as you come into the season for COVID and for influenza, and for that matter, thinking about resident vaccination and long-term care, it's about looking at that list of things you can do, asking what resources you have to put in it, who the people are on your team that can do it, what their strengths are, what's the simplest and most effective thing you can do this year to improve vaccination rates, and then coming into next year, reframing it, recycling what you've done before, adding some new things, and watching success over time. It's obviously not no work. There's absolutely no miracles in it, but it can be something that you can fit into the system over time, and you just sit down every year and say, what is possible this year? What can we do a little better than last year? And you keep building over time and ending up with higher vaccination rates. And there you go. Here's some things that people have done. Okay, photos of people champions getting vaccinated, lists of reasons to get vaccinated, many different choices, and lots of resources online that you can use to help with each year's campaign. And with that, I will say thank you, and hopefully we've left enough time for some questions and discussion.